afternoon. Well, my contribution to our programme of research on catheters centres on how catheters are used in acute care and how we can avoid unnecessary use. Healthcare-associated UTI is prevalent both on admission to hospital and also during hospitalisation. And this graph was data collected from a European-wide prevalence survey in 2011-12 and shows that the pie chart on the left-hand side shows that UTI is the fourth most common healthcare-associated infection on admission to hospital. On the right-hand side, you can see it's the second most common infection acquired during the course of a hospital stay. This same survey demonstrated that 60% of healthcare-associated UTIs are associated with indwelling urinary catheters. Catheterised patients, whether or not they have an infection, have bacteria in their urine, and I think Sandra's work very nicely demonstrates how quickly biofilms form on catheters. And so these patients represent a huge reservoir of pathogenic organisms in the hospital setting, including antimicrobial resistant strains. And of course, in the hospital environment, they're well placed to spread between patients. There's lots of opportunities for these pathogens to spread. We know that catheters are overused in acute care. In the hospital where I work, we do a point prevalence survey once a month as part of the NHS Safety Thermometer initiative. And this data tells us that on a single day, 1 in 4 patients has an indwelling catheter in place. These are the most common indications for catheters, and I'll come back to the first two shortly. We know that 6% of catheterised patients at any one time is on antibiotics for UTI. But it's actually very difficult for clinicians to distinguish between those patients with a catheter who have bacteria in their urine but not an infection, and those who actually do have an infection. And so we can end up with a lot of overuse of antimicrobials, thereby increasing the problem of antimicrobial resistance. And so avoiding unnecessary urinary catheter use is a hugely important preventative strategy. We did a systematic review of interventions to minimise initial use of catheters in acute care. Most of the research we found, so 971 studies, addressed the problem of duration of catheter use, and so looked at timely removal of catheters, which is important. And again, because of the speed with which biofilms form, we don't want catheters dwelling any longer than they need to be. But we found just 8 studies that were looking at interventions to reduce the initial use of catheterisation that we could include in our review. Most of these were poorly designed, uncontrolled before and after studies, and so we had to conclude that the evidence in this field is insufficient and we need further work. But a very interesting outcome of this review was the variation in between studies in their accepted indications for catheter use. These were all studies that took place in a hospital environment, and you would expect the degree of variation between studies. So these are the 8 studies across the top here, and these are the indications for catheter use down the side, because these studies were undertaken in a range of different clinical environments. But nonetheless, the difference is striking. You would expect perhaps there to be more commonality between uses. So how do we determine what the appropriate indications for catheter use actually are? And how can we ensure that catheters are only used when necessary in clinical practice? We were interested to find out more about clinicians' decisions to use catheters in acute care, as little is known about this. And Cathy Murphy, who's here today with us, is a member of our research group and recently completed her PhD on this topic. This was a qualitative study looking at investigating doctors and nurses working in acute medical care to understand their decisions to place a catheter. Think Aloud interviews were used with individual nurses and doctors close to the time of making the decision to use a catheter. And so these interviews were focused on individual patients and why they were catheterised. 2/3 of these same nurses and doctors were then followed up with a more detailed, semi-structured interview to understand in more detail their practices more generally, rather than simply related to one patient. Key findings included that there was wide variation in opinions about when a catheter is warranted. Interestingly, most clinicians perceive the risk of infection from catheters to be low, and therefore this didn't generally influence their decision to use a catheter. There are a number of patient-related and non-patient-related influences, including the clinical environment where the patient was being managed, resources available, the patient's own age and gender, and also staff workload that had a bearing. Clinicians identified the goals that drive catheter use in practice, which often conflicted with the accepted reasons for use given in guidelines and in the literature. I'm going to give just 2 examples now of indications, so I'll come back to these. So 44% of patients who are catheterised in the hospital where I work are catheterised for urine output monitoring. And for patients who are critically ill, it's a perfectly justifiable reason to use a catheter because it's the only feasible method where we can monitor hourly output of urine. But there are several ambiguities about this, which are listed here. Firstly, who counts as critically ill? Why is urine output being monitored? How is the information being used by clinicians to provide treatment? And one of the important distinctions is, does the patient need hourly measurements of urine or accurate measurement of urine output over several hours? And this is an important distinction because the latter doesn't require a catheter, and yet people tend to be quite cautious and just put a catheter in because it feels like the right thing to do. And Cathy's research demonstrated this very clearly. Cathy found that clinicians tended to widen the definition of critically ill to include patients they wanted to keep an eye on. It was reassuring for the doctors or the nurses to know that the patient was catheterised because they'd more likely pick up someone with reduced urine output that needed to be acted upon. And this was a particularly reassuring factor in the fast-paced environments of the emergency departments and the acute medical units, where they were worried that these things may get missed. Okay, thank you. Doctors commented that it was easier to justify putting a catheter in rather than not. Junior doctors often felt that it was better to do it because they didn't want to feel silly in front of more senior colleagues for not having a catheter in when one was felt to be necessary. Given the time limitations, I'm going to skip the other example but move on to my conclusions, which would be that the decision to use a catheter in acute care, in fact, is complex and multifactorial. So it's not simply a case of having a guideline and following the rules. We do need more evidence on when the benefits of catheters outweigh the risks. And if we're to develop successful interventions, we need to understand more about why catheters are used in practice and how decisions are made. We also need to try and support nurses and doctors and also patients and change their expectations about when catheters are used and why. As Mandy mentioned earlier, it's really important to provide viable alternatives. It's one thing saying avoid use of a catheter, but actually we need to put a lot of energy into thinking about what could we do instead. And I think certainly the contribution Cathy's research has made, and certainly in my clinical role, I see it all the time, that we need to develop solutions that are specific to particular clinical indications, so urine output monitoring or urinary retention, and also the environment where patients are being nursed. And we tend to go for these solutions that are a one-size-fits-all, and we know with this particular conundrum that's not going to be useful.